Good morning and welcome everyone to this webinar, which we have titled Biological Sampling from the Community to Support Research. I think it's a long-awaited webinar and exciting in itself because I believe many of us have had some experience with regard to biological sampling. It could be in research, it could be as part of clinical care, either as a provider or as a patient. We have either had a blood drawn or some sample taken, or we have actually taken some people's samples, be it in a clinical setting or in a community setting. But suffice it to say, taking of a biological sample is a big deal in itself. And especially when you're doing this at the community level, which then presupposes that you have received consent from the individuals and you're going to take that sample. Now, the question is, how do you even arrive at the point where you will request somebody for consent? How do you arrive at the point where somebody will agree for you in a community setting to take their biological sample for one good reason or the other? Not to even speak of the ethics behind securing ethical clearance to do this kind of work. So in my short submission, I'm just trying to outline just a couple of hoops across the board, from ethics through to the actual science itself, the bench science through to the science of engaging with individuals and with communities. And this morning, I'm going to hand over to the moderator, Dr. Afum Adjei-Awuah, who will introduce the speakers one after the other, and he will also give us a brief overview of what today's topic is about. My name is John Amuasi, and I lead the Global Health and Infectious Diseases Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine in Kumasi, Ghana, and I'm head also of the Global Health Department at the School of Public Health at the Kwame Nkrumah University of Science and Technology. So thank you very much to all of you who have joined us thus far. We look forward to a few more joining us, and I believe it's going to be an exciting time. Tony, over to you.
Thank you very much, John. I'm excited to join you here. My name is Anthony, and currently a postdoctoral research fellow with the Global Health and Infectious Diseases Research Group here in Kumasi, Ghana, and I'm also the PI for community of practice for the pandemic and for biological sampling during pandemics with the TGH in Ghana. So today we have four very distinguished and experienced presenters who will share with us their experiences in biological sampling in the community to support research. Before that, a few housekeeping rules for you. Now, this webinar is being recorded and will be shared on the Global Health Network platform online, and so we thought we should be aware of this. Due to the number of participants, your camera and microphones have been disabled. Please use the chat function to introduce yourself or report any issues you may have during this session. I would like to also add that we will try to get through as many as possible questions, and you put your questions in the chat box. We may follow up if they are unable to exhaust most of the questions. This session is chaired by Dr. John Amuasi, who is the group leader for the Global Health and Infectious Disease Research Group and also the PI for the TGHN Ghana. I will be moderating. There are four speakers: Dr. Mandro Ndahura Michel, Dr. Emmanuel Kwadzo Ahiable, Dr. Atinuke Olaleye, and Augustine Eschollar Sagoe. We had a little close to 600 people who registered for the webinar, and you can see from the infographics that these are from all over the world. For those of you who just joined, I'd like to remind you, you can tell us your name, where you are joining us from, and which institute you are joining us from in the chat session. So the first speaker for today's webinar is Dr. Michel Mandro Ndahura, who was born in Bunia and based in Kinshasa. He's been a medical doctor since 2004 in the Democratic Republic of Congo. He has worked through all the levels of the country's mid-level health system. He has worked as a lecturer at the University of Bunia, and from 2011 up until 2021, he has been the head of inspection and control office for the Ituri Provincial Division of Health in the DRC, where he is also offered his expertise in support of the MTN program. He is working for more than 15 years in the field of NTD's research projects and clinical research associate and clinical trial investigator. He obtained his degree or his PhD in medical sciences at the University of Antwerp in Belgium in 2020. Since April 2022, he has been appointed to take the role of the NTD Regional Program Manager for Africa, West and Central of Christian Blind Mission. Ladies and gentlemen, I introduce to you Dr. Michel Mandro Ndahura. Michel, you can take over and begin your presentation. Thank you.
Thank you, Anthony. Okay, so today I'm going to share with you a very specific or particular experience of a study conducted in a very complex and challenging area of the Republic Democratic of Congo, where we have set up a clinical research center continuing the development of a new drug called moxidectin, which will be used to accelerate the elimination of onychomycosis. And then we also include an experience with COVID-19 pandemic. So this is the area where the study was set up, were conducted, implemented. So as you can see, it's a very long period of study, which is a 5-year study. And you know, if you are implementing a very long study in a very complex and rural area, you will expect to have a lot of challenge in terms of logistics, security, and again, we had this global pandemic, which really comes to complicate the situation. So is very northeast of the country in DRC and bordering with Uganda. And in red here, you can see where participants in the study were recruited. It was between two health districts, Logo and Nyarambe district. So the study was launched in area May 2021. This, as you can remember, was a critical period where COVID-19 was really a very big global emergency in the world. So I want to give you a kind of background of the study here. We are conducting two main studies. So the first one is an efficacy study, which is trying to compare the efficacy of the new drug, moxidectin, compared to ivermectin. And then, as you can see, the main inclusion criteria to participate in the study was a skin snip collection, and then more than 10 microfarad per microgram of skin, and then to be included in the study. And you can see at each follow-up period, time point, meaning 6 months after recruitment, 12 months up to 24 months, each participant has to have skin snip in order to see the impact of the drug on the decrease of the microfarad load. So you can imagine that it was a very huge amount of skin snip and then microfarad that has been collected. And then we were expecting to have 1,000 participants in the study. And again, we are also expected to have this 1,000 participants during 6 months only. But you can see here, the recruitment period took a very long time. We went to 2 years. This will be because of COVID. And then we have also another study, which is a safety study, which was a very short one, about 3 months. And then too many inclusion criteria was living in the pandemic area, and then also if we have positive people with less than 10 microfarad per milligram of the skin. So, and here we took 2 skin snips for each participant, and then we're expecting to have 12,000 participants in the study, and the study was supposed to take 2 years for recruitment, and then we stopped the recruitment last year, but we didn't reach 12,000. We slightly had 8,000 participants in this study. So this slide is showing how we deal with separate transfer or aboard shipment from the study site to the west. I mean, we have 2 sides. We have the left side and then we have the right side here. So the samples collected were Ocoseca volvulus parasite that was sent to La Trobe University in Australia, and then we had serum and urine which were sent to Smith College in USA. So we are crossing the border of Uganda in order to reach Entebbe airport, and from there the samples are sent to the 2 universities, and we are using local roads with study vehicle to reach the border, and then from the border to Entebbe we are using a transfer agency called Union Logistic Uganda, and then we are using World Courier transfer the samples from Entebbe either to La Trobe University or to Smith College in USA. So COVID, what was the impact of COVID on the biological sample in the country? You can only see here on this photo that we were obliged to comply with the national COVID-19 protocol during the study procedure. And then it was mandatory to conduct training of the staff and also for the community in order to talk about COVID and then about how to prevent the risk of getting COVID. So this need additional resources that we didn't plan for at the beginning, because at the time we were preparing the study, working on the protocols, it was very either before around 2019 or 2018 where COVID was not there. And then when COVID started, it was exactly when we're supposed to start the study. And then we were obliged to now include this component in our procedures. And then again, it was mandatory to not go over 20% in the community meeting. You know, this study was a community-based study where we had to sensitize people, to also screen people among the community. And then we were obliged now to reduce the number of people attending our meeting in the village, and then we had only to respect less than 20 people per meeting, and then this reduced too much. It's extended too much the time of recruitment, and then it was also mandatory to wear masks whatever you'll be in the community, and then people did not have this behavior of wearing masks. We were obliged to sensitize them, to provide masks to them, and then you can see how difficult that was, and then it needed additional resources as well. So this figure is showing how the COVID-19 impacted to the recruitment procedure, which is showing in this very busy slide, but we can just look at the yellow colors here, where during the community meeting, we are obliged to take 1 to 2 hours to sensitize community on COVID. And then when we had this population willing to participate in the study, they will again come to the entry point of the study. And again, before conducting the informed consent procedure, again, we had to screen for COVID, take body temperature, if someone gets been a probable suspect cases, this has been referred, it was referred to the local health centers, and then later on, all the others has to be included in this recruitment procedure. So you can see how this impacted too much the duration of the recruitment. So another consequence of COVID is, at that time, the border of countries were closed. So this was also the case for Uganda border that is closer to our study site, where we were supposed to transfer the samples, and then no shipment could be planned during that period. And this leads to an overload of the storage capacity in this site. And then we were obliged to buy 2 more fridge, and then even destroy around 200 first alien samples because we could not have more spaces to store them. And then we talked about this already, that the study was launched in May 2021. Just a few weeks later, the principal investigator was contracted COVID himself, and then he had very severe symptoms and obliged to be hospitalized in emergency in a hospital. And then again, he contracted this disease in Uganda when traveling for study purpose in order to try to work on some administrative tasks. And then this really impacted on the activities on the ground. And this is another information that, working in this rural area, many things can happen. We lost a very experienced, a very good dynamic technician lab who was really working in packing the sample for shipment. And then definitely, and at the end, we had our first shipment only in March last year. So it means that after 2 years, we only had our first shipment in March 2023, after COVID has been declared not to be a global health public problem. And then the second shipment occurred in March this year. So this was our main challenge for what we even were prepared outside of COVID. We knew that we are working in a very insecure setting. And this is a map showing Ituri province. And you can see here, all these lists are the armed group which is operating, which is active in the province. You can see in different colors and different numbers, 11 armed group operating in the area. And then here where we have the study site, it's this color, and then we have this group called Codeco. They have a kind of 4 subgroup of Codeco operating this area. And again, another things you have to read on this map is that this site is located 2,000 kilometers from Kinshasa, which is capital city of DRC. This is because normally officially the samples which is leaving the country has to pass an official route, which is through the capital city. But we could not use this official route because of the distance, because of security issue. That is why we are obliged to use this shortcut from the site to Uganda capital city, which is Kampala, located to 450 kilometers for the site. And then we succeeded to use the border of Uganda and DRC in order to ship these samples, and then we had checked by the customer services. This is mentioning because we had to pay some amount of monies here in order to make the samples to cross the border. And here, this is showing how we brought the samples from the village, from the study site to the border, and to transfer them in the Union Logistic Uganda lorries truck, and then every time it will be like that. So this need a kind of really good communication and organization, logistical organization. So this was microfaria of okosekiasis before shipping. We had to really pack them, to put them in order, and then even to include the result of each samples, because they are going to do a kind of quality control where they've been sent. And then again, we had this rural condition where the road is not always easier. And then we got this problem all the time. And here we are mentioning this because I said before, we are working in a very insecure setting. Even circulation of the material, circulation of the study staff, it's really challenging. That's a very difficult area where the rebels are really active. And then they have also to do a kind of checkup of all the materials circulating in the area. So this is my two last slide. So the main challenges are summarized here. It was really a challenge to getting specific shipping sample material. You know, this truck which was coming for Uganda had to bring some specific materials to the site. From the site, they went to take the sample, put it inside, and then come back into the border in order to ship them. You know, conserving samples was not easier. You know, there is rebels I'm talking about. Issue with national and neighboring officials. This was really costful for the project. Challenge with transit such as local DHL or transport company. Cost with international transport companies such as World Courier. And then we have some recommendation. Despite this COVID and unrest in DRC, we succeeded to really conduct this study and then also to collect, to manage, to ship the samples in respect to the standard of our study protocol. This requires, of course, additional funding, and then we hope that this experience of moxidating study could be in a very important opportunity for DRC to use it for developing a good lab development and then strengthening in the country in the view of disease elimination and also for research purpose. Thank you very much, and I'm ready for your comment and question.
Yes, thank you very much, Michel. We really do appreciate sharing your experience with us. And we encourage people to, at this point, put their questions in the chat box. We'll pick up on them, and towards the end of the presentation, we will begin to answer the questions for you. Next speaker is Dr. Emmanuel Kwadzo Ahiable. Sorry, let me adjust my video quite a bit. All right, so Dr. Ahiable obtained his medical degree from a high Institute of Medical Sciences in Havana, Cuba in '95. Had his MSc degree in Health Services Planning and Management from KNUST in 2006, and his specialist MSc degree in medicine, specializing in emergency medicine in Cape Town, South Africa in 2017. He was the medical superintendent at the Ashanti Mampong Government Hospital from 2005 to 2011, and the Deputy Director of Clinical Services, Institutional Care Division of the Ghana Health Service in 2017, an emergency physician specialist at the Greater Accra Regional Hospital, REACH, in 2017. He is currently the COVID-19 National Case Management Team member and COVID-19 Case Management Lead at the Greater Accra Regional Hospital at REACH. He was awarded under a category called the Frontline COVID-19 Heroes, introduced by Humanitarian Awards Global to unearth and appreciate outstanding health workers and staff from several institutions who have been very instrumental in COVID-19 fight. Dr. Ahiable has worked through the ranks and has such an experience, especially in the management of the pandemic, and I'm happy to introduce him to you and present him to share his topic. So Dr. Ahiable, over to you.
Thank you. Thank you for the nice introduction. I kind of you. My name is Dr. Emmanuel Ahiable, and like the moderator said, I'm the National Case Management member and a lead at my hospital during the pandemic. It's interesting to know that in the next slide, my hospital was the hospital that received the first COVID-19 positive case in the whole of Ghana. And happy to be the lead The first case was received 2020, March, and I was the first person to receive the first case. So I have a lot of experience in the management of COVID-19 as a clinician and as a public health practitioner as well. Next slide. The outline of my presentation is a simple one. I'm going to give brief definition of pandemic, talk about the strategic preparedness and response plan for the WHO African region, and what biological science samples are, challenges in the collection of biological samples, so far as my hospital in Ghana is concerned. So the first slide will be on a definition of pandemic. As we all know, a pandemic is an epidemic of an infectious disease that has spread across a large region. For instance, multiple continents or worldwide, affecting a substantial number of individuals. We have a couple of pandemics in the world. Basically, they are flu, they are viruses. We have the Spanish flu pandemic in 1918, Asian flu pandemic in 1957, Hong Kong flu in 1968, the swine flu in 2009, and the COVID-19 pandemic, which we are all witness to recently. That's like this. So WHO, the African region, Afro region, had a strategic preparedness and response plan for COVID-19 in the entire continent. And among the numerous achievements, the key ones were there were early and rigorous risk assessments and development of COVID-19 preparedness and response plans, which facilitated early response in all the 47 countries in Africa. There was establishment of laboratory genomic diagnostic network of COVID-19 confirmation and further characterization through sequencing. So therefore, all the 47 countries had laboratory capacity for detection of COVID-19 using the PCR testing, and finance and material resources were being mobilized, including distribution of supplies such as personal protective equipment, PPE, laboratory equipment and reagents, as well as other medical services, devices, including oxygen concentrators, patient monitors, etc. Next. So despite all these key achievements, there were some challenges by the WHO African region, and prominent among the challenges were the lack of political will in some countries, poor compliance to some WHO guidance that's limited, complicated coordination of a timely response to the 47 countries. There was also a reluctance of couriers to ship laboratory specimens due to fear of COVID-19, as my previous presenter has enumerated. There was a constraint in availability of local health products and supplies requiring procurement and importation from countries outside the African region. So challenges with procurement and supply functions persist, which may be due to border closures, general shortages in the global markets, challenges related to a longer turnaround time for orders, and inaccessibility of some of the goods in the UN supply portal, as well as suboptimal coordination and information sharing among partners. And like I said, the first presenter mentioned some of the challenges. Was key. Next slide. So despite all these challenges, there were opportunities. The opportunities in the African region. Next slide. So among the opportunities which has enabled us to do the presentation today was with the availability of more options for testing, including using the rapid diagnostic testing, that is the RDTs. Improvements in the national testing capacities are expected in the future, and of course, it's improved. Then there are several vaccines and therapeutics in phase 3 trials showing efficacy of 90% in the preliminary analysis, presenting an opportunity for countries to revamp up vaccine readiness activities. The slower emergence of the COVID-19 pandemic on the African continent than other global regions provides an opportunity to review and understand the factors contributing to the resurgence in the other regions and the use of fundings to inform planning processes and strategies for African continent. This is critical, given the fact that most of the health systems in the continent, African continent, were weak before the pandemic. The fact that the pandemic has slowed down, which of course is slowed down in Africa, now it provided us the opportunity to conduct quality interaction review to identify best practices, bridge gaps, plan for resurgence, and improve the overall quality of the response. So now go straight to having enumerated some of the strategic planning. What are biological sample, or what are biological samplings? So biological sampling, the next slide. What is biological sampling? Now, biological samples are biological materials that are collected from living organisms or their environments for research or diagnostic purposes. These samples can provide valuable insights into understanding various physiological, pathological, or genetic processes. This can include anything from blood, serum, urine, to tissue samples such as skin, muscle, organ tissue, as well as cell cultures and DNA samples. Next slide. So what are the importance of biological samples in research? The importance of biological samples in research spans many fields, including medicine, genetics, microbiology, and many others. These samples are essential in understanding the underlying mechanisms of diseases and how they can be treated or prevented. They are also used in the development and testing of new drugs, therapies, and vaccines. The study of biological samples has enabled the identification of numerous biomarkers, which are specific molecules that can indicate the presence of severity of disease. Additionally, the analysis of DNAs had also led to advancements in personalized medicine, allowing doctors to tailor treatment to an individual genetic makeup. So what are the challenges of working with biological sample? Next slide, please. Working with biological samples presents challenges such as sample storage, degradation, contamination, and variability. Next slide. What are the ethical considerations surrounding the collection and the use of biological samples? Ethical considerations when collecting and using biological samples include privacy concerns, obtaining informed consents, and ensuring that the research, is conducted in an ethical and responsible manner. So the next slide. What is the importance of properly handling and storing biological samples? The proper handling and storage of biological samples is critical to ensure that the sample remains viable and to prevent sample degradation, contamination, or loss. This is important to maintain the integrity of the sample, allowing for valid and reliable research results. Next slide. Now, my story. My story as a researcher and as a clinician. We embarked on a study which was started in my hospital in collaboration with the West African Center for Cell Biology of Infectious Pathogens, the University of Ghana, Legon, Accra. The study was approved by the Ghana Health Service Ethics Review Committee, RB, on the 27th of July 2020, at the peak of the pandemic. So the title of the research is Host Genetic Factors Mediating Response to SARS-CoV-2 Infection. So like I said, it was in collaboration with the West African Center for Cell Biology of Infectious Pathogens. So the University of Ghana. Next slide, please. So the objective, the goal, and the aims of the study, the long-term objective of our study is to develop a framework for systematic approach to understanding host microbe characteristic interactions to be able to deal with emerging future infectious healthcare threats or resurgence of the current pandemic. The immediate goal is to learn about the host's genetic determinants for SARS-CoV-2 infections through collaborative identification of genetic variants and examination of the role of these variants in the available cellular and animal models. The study aims at providing translatable information for surveillance, testing, and treatment. It also aims to ascertain and recruit a cohort of patients with positive SARS-CoV-2 tests and obtain detailed and temporal symptoms and clinical pathological findings. The whole exome sequencing with bioinformatics analysis for common and rare variants, and copy number variants and analysis for phenotype and genotype correlation patterns. The examination of the role of identified variants and the genes deemed as host genetic determinants in the susceptibility and severity of COVID-19 in respiratory epithelial cells, as well as SARS-CoV-2 adapted mouse model. Next slide. Next slide, please. So the key challenge we faced. Now, the key challenge we faced, the key challenge we faced as a team, the main one, even though there were other challenges, the sample collection dragged on and the interest in the project waned. As I speak now, we are having difficulty. We haven't completed the project or the study because of this major challenge. We aren't getting the numbers. Next slide. So there were other challenges. Next slide, please. Other challenges which, we had the collection of biological samples where resource constraints. We have limited funding to carry on this study. We have limited supplies and equipment. There was a resource hampering of resources for procurement of sampling kits, laboratory facilities, and personnel training. Health infrastructure inadequacy. Availability and access can hamper or hinder sample collection because we didn't have enough, study sites. So we had difficulty collecting the samples. The numbers we're getting from my side, my hospital, and other hospitals were not enough. So we have difficulty getting access to other facilities for sample collection. And there was inadequate transportation infrastructure, which can impact the ability to reach certain communities for sampling. Because we wanted to extend and go to other communities and collect more samples, but there was difficulty. If there isn't a proper coordination among clinicians, researchers, etc., it impedes sample collection. In my hospital, for example, there was poor collaboration among some of my staff collaborating with the Center for Research from the University of Ghana, Legon. So this can also hamper if there's no good collaboration among them. And ethical considerations, if not considered, can also impede collection. In our case, it took a long time for us to get the ethical clearance for the work to start. So when we were about starting COVID-19, we're not getting cases again. There was no more becoming a public health emergency. So these were some of the challenges we encountered. I think this will be the last nice slide. Next slide. So these are my references. The two most important references I made. Next slide. This is the end. Thank you very much for your attention.
Thank you very much, Dr. Ahiable. Thank you very much for your thoughtful insight and presentation. For those of you who just joined us, please remember to tell us about yourself, your name, your current institution and country you joined from. In the chat, there's the Q&A session, and please feel free to put your questions there. Michel is the speaker. The first speaker is already answering questions that were put in the Q&A, and so please make sure your question is as direct as possible to guide the speakers to be able to answer for you. We will take our next presentation, and it will be given by Dr. Atinuke Olaleye. And Dr. Atinuke Olaleye is a board-certified obstetrician gynecologist, a fellow of the West Africa College of Surgeons, and the National Postgraduate Medical College of Nigeria. She holds a WHO TDR Clinical Research and Development Fellowship, as well as an EDCTP Career Development Fellowship. Her research interests include malaria in pregnancy, perinatal transmission of infectious diseases, and adolescent sexual and reproductive health. Dr. Olaleye was the director of the Center for Advanced Medical Research and Biotechnology, Babcock University, Nigeria. She's currently a physician at the Two Hills Medical Center in Alberta, Canada. Ladies and gentlemen, I present to you Dr. Atinuke Olaleye. Over to you.
Thank you very much for that introduction. Hello, everyone. I will be talking about the challenges of biological sampling for community-based research and looking at it from the lens of the lessons we learned from a study on placental malaria in Nigeria. Next slide, please. So I will be using this outline as we go along. Next slide. So, essentially, I know most of us are from African a region, so we are familiar with malaria in pregnancy. We know that it carries a lot of risk for morbidity and even mortality for both mother and baby. And we do give intermittent preventive therapy with the common medication had been sulfadoxine pyrimethamine to prevent or reduce the occurrence of this issue. But we knew that there was resistance being reported to this particular medication. And so this was what brought about this particular study that was done to look at the parasite resistance to the medication being given for preventing malaria in pregnancy. Next slide, please. So this was actually, the study title is the determinants and prevalence of parasite resistance among pregnant women receiving IPTP with sulfadoxine pyrimethamine in Nigeria. And the objectives were to determine prevalence of these molecular markers of parasite resistance, to explore factors that could be affecting this prevalence, see if there were any notable differences between both the peripheral and placental parasites when looking at the molecular markers of resistance, as well as look at clinical outcomes with respect to maternal, fetal, and neonatal outcomes among women who did have evidence of this parasite resistance to the sulfadoxine pyrimethamine. Next slide, please. So this was essentially a blend of facility and community research because in the primary endpoint, we're looking at the resistance gene markers, but in the secondary endpoints, in addition to looking at parasitemia in both peripheral and placental samples, we're also interested in looking at the occurrence of parasitemia both pre and 28-day post-IPT, and also we did this continuing even post-delivery. So 7 days and 28 days post-delivery, we also did testing to check for malaria parasitemia. So we had to go to their homes as well to do that. Next slide, please. So this essentially was a study funded by the EDCTP, as European and Clinical and Developing Countries Clinical Trials Partnership, as a career development fellowship research grant. It was a prospective cohort study among 500 pregnant women, which was conducted between 2018 and 2020. So we actually were just about wrapping up our study when we had the peak of the COVID pandemic. It essentially was done in Ogun State, southwestern Nigeria, and we used both rural and semi-urban communities. So we didn't actually use a city per se. They were just towns and rural communities. We essentially worked with 4 health facilities, a tertiary one, secondary health facility, and 2 primary health facilities. Next slide, please. So this just gives you an idea of some of the places where we worked. To the left, to your left was one of the primary health facilities. The right is the secondary health facility we used. Next slide, please. On the left is another primary health facility, and then on the right is the antenatal clinic of the tertiary health facility. Next slide, please. So the specimens we actually collected were maternal blood, which was taken at enrollment and pre and 28 days post IPT per time, and IPT with the SP was given monthly. So we took cord blood at delivery from the placental end, and we also took some placental tissue samples as well. And the tests we ran were the RDTs, the microscopy. We had filter paper blood spots for PCR. We checked their hemoglobin concentrations as well as placenta smears on the microscope slides, as well as histology specimens were taken. Next slide, please. So in preparing the study team for this, we had a lot of trainings. I just want to use the opportunity to highlight the fact that we did get a lot of valuable online resources from the Global Health Training Network. A lot of the trainings were done through that. And then we had face-to-face trainings as well, lab staff. But of importance is the fact that we had a lot of trainings with the healthcare staff in the antenatal clinic and the labor and delivery units of the study sites. I should mention that 3 out of those sites I mentioned, so the secondary and the primary care healthcare facilities, they were all government owned, while the tertiary healthcare facilities was privately owned. So there was need for collaboration. And in the trainings that were done, I specifically highlighted the informed consent and communication skills trainings, because this came really, really handy in the challenges we faced. Next slide, please. So in this side, the pictures you're seeing, these were the peripheral sites that we used, some of the government sites. So the staff there were the ones we were putting through the study to understand what it was all about, so that we could also have their support. Next slide, please. Now, in the stakeholder engagement, this was a key component of this study, and we had to go at various levels. So at the government health authorities, we were able to approach the State Ministry of Health, as well as the local medical officers of health at the local government levels, to be able to secure, apart from not just getting clearance from them for the study, but to actually collaborate with them. And this was also with the health facility administrators of the specific facilities we worked with. And this helped out in the sense that, for instance, the malaria program officer for the state where we worked was able to provide us with a project liaison, and that person ensured that we had uninterrupted supply of the sulfadoxine pyrimethamine that was used for the IPT, because it was provided free by the government to the pregnant women, but there were always problems with supplies and stockouts. So they were able to avoid that during the study. Also, they made sure that the insecticide-treated nets, which were supposed to be provided to all women as well as part of the malaria program, were also provided, avoiding stockouts. Then, in addition to that, the local government medical officers of health were able to provide for us the nurses at these government health facilities who were given permission and time off to attend our project team meetings, so that we could actually get to know in depth about the study, understand what it was all about, and we're now the focal persons within their own facilities coordinating the activities. We did have a lot of engagement with community leaders and members. I'll talk about that in the next slide. And then, of course, with the pregnant women themselves and the study site staff. Next slide, please. Now, in the community entry, I'm focusing a lot on the issue of community because for our part of the world, the first issue is you want to do research on pregnant women. That's already an issue. Pregnant women, people don't want to say we are doing research on them. 2, we're talking about taking placental samples. And placenta is something that they take very seriously in our part of the world. So we had to go, we had a lot of discussions with the traditional leaders, the community health advisory boards, which were people drawn from within the community who are the ones that listen to and approve public health initiatives being brought into each community. So we had to talk with each of these boards within the various communities, as well as the religious leaders and opinion leaders. Next slide, please. So this is just an example of one of the meetings we had. So the lady on the right who is standing is the local medical officer of health for that particular community. So it was really important to have their presence at these kind of meetings, showing support for the study to show that this sub-study is safe, they can be done, that they support it. And so when these health advisory board members saw that and were able to ask their questions and were able to clarify matters, they were in turn able to go back to the community to say, oh, we have heard from not just the researchers, but from the government people who are also supporting them, and we also support this study. Next slide, please. This had to do with the religious and opinion leaders. We also had the public health educators from the government. They were also brought in because they have interactions with the leaders on a regular basis. And so they were able to also help garner support for the study. Next slide, please. This was with the pregnant women, where we were able to ascertain that they were aware of the study and they were aware that their community leaders were in support of the study. Next slide, please. So I'll come directly to the challenges we faced. So the first one, despite all what we had done so far, the first one of the challenges we faced was about consent. Now, we know that in the clinic, when the women were coming to the clinics, they would come alone. But in getting consent for these kind of studies, they would require this, most of the time would say, oh, they required the consent of the spouse. So what we had to do in this instance was to make sure we had the subject information sheets that we had. We tried to make sure that the women were recruited actually between 16 and 28 weeks of gestation. So what we tried to do was that at the very first antenatal clinic visit, even if they were not yet at that point, if they're still about 4 weeks or something before that particular age of enrollment, gestational age, we would have had that discussion with them. We gave them those subject information sheets. They were able to take it back home to discuss with their spouses about it, so that when they were coming at the next clinic visit, they could let us know whether they consented or not. Some came with their spouses, asked questions, and this was clarified. The other part of the consent also had to do with the consent for the blood sampling that was going to be taken from the baby after delivery. So in that instance as well, sometimes it was the spouse that would give the consent, sometimes it was the woman that would give the consent. So this was very important. That's why the informed consent training was very helpful and very important for the staff to understand. Now, there was the issue about blood sampling in pregnant women, like I mentioned. This was one of the challenges we faced, but we were able to also ensure that we took only what was needed. We were very clear, even in all the study information, about how much blood was taken, how frequently to be, and the fact that it was not going to be detrimental. It wasn't going to make them anemic in pregnancy, because that was one of the concerns. Now, a big issue we faced with this study had to do with the cultural perceptions and rituals regarding placenta. Now, in our part of the world, there's a lot of cultural and religious beliefs attached to the issue of the placenta. And so it's believed, usually when babies are born, the family takes the placenta, and then they either do some cultural rites or spiritual things or prayers, and they tend to usually like bury the placenta. It's believed to have some impact on the future of the child that was born. So hearing that people wanted to take the placenta, there was a lot of resistance at the beginning. So one of the things we did was to also get representative models. So what we just did was we used just like the foam from the mattresses, we cut samples of the exact size of the placental specimens we needed, which was just about 1 to 2 centimeters by 2 centimeters, just like the fingertip size. So we were going to take about 2 or 3 of those ones. That was what we needed. So we put this kind of models, and then we made sure it was at every of our meetings, it was in the clinic, so that the people could understand that we are not collecting.
I'll let you there. We are not, we are behind time. So.
Oh, yes. I'm almost out. I'm looking at, yeah, I have a minute more. So we did that as well to show them that this was what we were going to do. And some of the, so this was able to help. Then at delivery, we noticed as well that we had some challenges with family members who were not part of the consenting process that were concerned about taking placenta and all that. Then one other challenge we had was the delivery of the study subjects at other locations. So even though they had consented and said they were going to deliver at the study site, they found out that particularly there was a mission house very close to the tertiary hospital, the main study site, where the women were actually going to deliver, even though they were coming to get their medications and other things in the hospital. So my last slide, I will show how we approached that particular challenge. So the lessons we learned really from this were the value of early community involvement and feedback. So we were able to address some of these issues by getting the community involved from the start. Really paved the way and smoothed a lot of the hitches for us. And being able to leverage on these systems for collaboration really helped us as well. And monitoring of the study progress regularly helped us to identify, for instance, that the women were not delivering in our center, but were delivering in the mission house, and were able to quickly do something about that. And of course, the team training, like I mentioned, and we learned the need for context-specific flexibility and adaptability. If we go to my next slide, I will just show what that is. We just go ahead. So this was the mission home where the ladies were going. This is a weekly antenatal, pregnant women prayer meeting. But we now discovered, next please, that apart from the prayers going on there, they had somebody who was coming to also take blood pressure and stuff there. And so what we now did, next one please, was we were able to bring our staff to come there, and the women who were already registered and enrolled in our study in the facility were able to place these stickers for our study on their documents, which is the one that is in front there, so that the woman that was in charge of the mission home was able to let us know when such women were in labor and were able to still get the samples we needed. Next slide, please. So this was just an example of the adaptability I was going to mention. So in summary, it was a challenging study, but everything went well at the end of the day. So thank you very much.
Thank you very much. That was an insightful presentation. Please, just to let you know, for those of you who just joined us, kindly let us know who you are, where you're from, and your institution, maybe what you do in the chat. There's the Q&A session ongoing already, and the presenters are answering as many questions as they can in the Q&A. So if you have a burning question, you can put it out there. We will try and answer them in the chat, and there'll be a few questions that we will be able to answer during the discussion session. We move on to our next speaker, and next to speak with us is Augustine Eschollar Sagoe. He is an infectious disease specialist, a fellow from Dr. Lee Young-wook Institute of Infectious Diseases in Seoul, South Korea. He holds an MSc in immunovirology from the University of Havana, Cuba, a bachelor's in clinical microbiology and diploma in human identification from the University of Human Identification in Joburg, South Africa. He is the National Rapid Response for Infectious Outbreak Team Lead for Lab in Ghana. He worked with the WHO and the CDC-led Technical Expert Consultant Services on Ebola outbreak in Liberia. He is the technical lead for Innovate Medical Center Project, Ebola effort in Liberia, the Ghanaian team lead to Sierra Leone and Ghana. Walter Reed Army Institute of Research, U.S. Army Medical Research Acquisition Activity, 820 Chandler Street, Fort Detrick, Maryland, and is the newly appointed lab head at the Ghana Infectious Diseases Center at the East in Accra, Ghana. He is a WHO voluntary consultant assessor for the COVID-19 case management, monitoring, and evaluation in Ghana. I present to you Augustine E. Sagoe to deliver the next topic. Thank you.
Thank you, Mr. Moderator. Yes, the name is Augustine E. Sagoe, for short, Eschollar. That is me. Yes, I'm a doctor, but that one is not part of my name. My name is Augustine E. Sagoe, for short, Eschollar. Thank you. As the moderator said, yes, slideshow. View. Okay, let me continue.
Hey, Augustine, it's to the right. There's a big button at the top right of the screen. There you go. Fantastic. Yeah, just click that one there.
Thank you. Sure. So this is my center where I am right now presenting. Thank you. This center was built purposely for COVID-19. Then it takes care of all infectious diseases in Ghana. So I'm going to take you through a short introduction. I understand that we have limited time, so I will speed and go straight to the challenges and how we solve it in Sierra Leone, Freetown, Hastings. So therefore, we all know that biological sampling is a key. And let me tell you this for sure, that I have been in Congo twice. So the doctor from Congo, I know him very well. Twice for Ebola in Congo, one in Kivu and one in Goma. That's 2011 and 2012. So for biological sampling, I can say that I'm a specialist in viral sampling. That one I can for sure. So we may take some samples like blood sample, saliva, tissue, part of a plant, or even sand. We use typically receptacles or swab in collecting these samples. So I will tell you some of the methods or techniques that we use in sampling. That is swabbing. For swabbing, it is the commonest one to do, but let me tell you the difficulties of sampling with swabs. Please, we are discouraging to use wooden swab and then cottonwood flogged swabs. Because when you use a cottonwood flogged swab, the tendency of the fibers of this swab to remain at the site of collection. For instance, the nasal canal, when we were taking samples for COVID-19, at the initial point where there was no enough sample kits, some countries, we tried to use the cottonwood flogged swab sticks. And by God, we noticed that most of them were reacting. Some of them were hypersensitive whenever we take the sample. So there was a research that came around that we did, and we found out that whenever we use the swab, which is cottonwood flag, there is a tendency, or there were some of the fibers that remained in the nasal canal. So we are discouraging using this. Also, we are discouraging using wooden swab because wood has pores in them, which reduces any transport medium that you will use. So instead of you getting a sample that can do 3 tests, you may end up getting 1.5 because of the swab stick that has reduced the transport medium. Also, we did blood sampling. The blood sampling, as all the speakers have spoken about, the blood sampling, what we have seen as a sample collection specialist is that most of us do not manage well the needle. So I will have a time which I will teach how to manage needles, whether with syringe or with back container, how to manage that needle. I will bring this forth the next time if there is opportunity. Also, we do environmental sampling. The environmental sampling too, whilst we are dealing with contact and then droplet form of transmission, then things may be contaminated through so many ways. But let me tell you this, for health sector, and then for we, the researchers, yes, we do tackle the doorknobs, the tables, but what we do forget all the time is the switch, the electrical switch. We do forget. And so when we did some of the research, we found out that yes, the room was okay, the knob was okay, but the switches, that is where we found these pathogens, these infectious agents. So please take note of that. Yes, we do tissue biopsy and then body fluids, several of them like urine, cerebrospinal fluid, and all that. So therefore, we cannot do all this without looking at the proper techniques for collecting samples, biological samples. First, I should have had a time to explain very well the wearing of the appropriate personal protective equipment, but here is the case that I will tell you that yes, we have to protect ourselves. We, the laboratorians, and then we, the ones that we take samples, we know for sure that when we are going to take any sample, the distance will be broken. The distance that we promote everywhere, the distance should be 1 meter. No, when you are going to take sample, that distance do not occur. So therefore, we have to protect ourselves based on the form of transmission that epidemics is taking. Also, you may use clean and sterile equipment just to avoid cross-contaminations. Then your proper labeling is the key. And then also when you label with undiluted ink or something that cannot be easily be faded or be diluted. Collect adequate amount of sample, as Dr. Atinuke has alluded already. Then also follow vividly or strictly your standard operative procedures. You should follow them vividly, no matter what. You should do that in order for you to maintain consistency and then the reliability of your research. These are what we could wear or we could use to protect ourselves to prevent the spread and then take safety of us so that we do save our community as scientists and then the community as a whole. Now is my take. Role of a community in a biological sampling. This, let me tell you one anecdote that happened in Sierra Leone when I was at Hastings managing Ebola treatment center. Once the outbreak was ongoing, it was hot up. Then WHO had us. Within that outbreak, we should do a research. So once we went to the community, and when we were going, I chose one person who was not a scientist, who was not a health worker, but understands well the community. He's the community member. So when we went, yes, at the entry, we had done everything possible to enter. But when we got there, we faced a trouble, whereby they told us, from my man who was chosen by me, that, hey, the people are saying they are preparing for us. They are saying it in their language, whereby all of us, we did not understand, but he that we chose to accompany us did understand everything. So I asked him, what is it? Then he told us that man that we are going to take the sample, the man is dead in the room. Yes, we knew it, but we were going to take sample. And then these people wanted one ring, antiquate ring. So because of that, they were going to chase us out. Therefore, what did I do? By then, Ebola time, everything that the patient dies with, the person should go with it. We don't take anything back. But for that antiquate ring, that was the community's problem. And it was our problem too. So what did I do? I chose 3 members from the community. They sat down, and then I chose 3 of us, which we sat down. Then I put a bucket full of chlorine of higher concentration in the middle of us. So they were looking at us, we were looking at them. Then I dipped this antiquate ring inside this and waited for 4 hours. It extended to 6 hours. Then I clean it, I remove it, I clean it. And when I was to give it to them, the whole community said that if I think that the ring is clean, then I should put it on my hand first. Yes, I did. And so they accepted it. Then we took our sample. We brought that body to the ETU for burial and others. This, in essence, it is something that I cherish so much that I want every researcher who is going to the community to understand and to include at least one community member who understands their language, not only the language, who understands their tradition very well, so that that person can help, though the person may not be among the researchers, but just co-opt him or her so that you will get your research successful. Key point, by involving the community in research, we can ensure that the research is truly impactful and then benefit all parties involved. This they have said everything. The lack of cooperation will come in. You should develop a strategy for every lack of cooperation that will happen, as Dr. Atinuke and my friend from Congo delivered.
Augustine, I wanted to just prompt you that time is...
Yes, I'm done. So this is the conclusion, is that by following safety protocol diligently, you will be safe, and then your community too will be safe. Don't forget to involve community member so that the community will accept your dealings in any way. Thank you very much, and these are my references.
Thank you very much. Thank you very much for the insightful presentation. Ladies and gentlemen, this brings us to the end of the presentations, and I would like to kindly ask that people put their questions in the Q&A, and the speakers are already in there trying to answer as many of them as they can. We've been able to curate a couple of questions that will help with the discussion session. We are almost out of time, but we hope we're able to push in some questions and throw it to the panelists or the speakers to address whilst we're still here. The first question I'd like to ask is, and this goes to all the speakers, you'd have less than a minute each to answer these questions. What do you think training really, how does training of the stakeholders involved in the research affect the ability to adequately take the samples and ensure that these samples are of the right quality to support the kind of study from the community? So given the challenges that you've all described in your respective studies that you came up with, what were the roles that training the stakeholders involved, either study staff or some of the community members, play in collecting these samples? I will start with Dr. Atinuke at the bottom and work my way all the way up.
Okay, thank you. You see, like in my presentation, I mentioned a lot about the issue of training, and I believe that there's no way we can't downplay the importance of training. First of all, for ensuring we have properly standardized sample collection that we can actually do assessment and analysis on. That's really important. But the other aspect I want to bring into that is the training also has to do with making it possible for them to be able, for the staff or the people involved, to know how to address issues that the community members raise when they are trying to collect samples. Why are you taking this sample? What do you need it for? Can't you use something else? Those kind of things. The staff need to know how to communicate these answers. Thank you.
Thank you very much. So, Dr. Ahiable.
Yeah, thank you very much, Anthony. I think training plays a very important role in sampling or collecting biological samples, because when those who are going to do the work are not trained properly, Mr. Sagoe, Augustine Sagoe mentioned that when we are taking samples, we should not use the cotton, the cotton bag to collect the sample because it can affect the results. Yes, exactly. So training is very important. Otherwise, we may get an outcome which does not represent what is on the field. In my case, for example, my hospital where we were doing the study with the University of Ghana, that's the cellular, this. I think what would be some of the shortcomings that's reflecting that my people were not actually sensitized enough. There was not enough sensitization. So they didn't understand what we're actually doing initially, but later it got better initially. So training of the staff or those data collectors that collect the sample is very, very crucial. So the right thing is done and they understand and buy in what we are doing. I'll end it here. Thank you.
Sorry, there's an internet disruption. We will go to Augustine.
Yes, Anthony. Yes, training is the pivot of sampling from your sample size up to the sample content, even the container, if it has to do with anticoagulant. Your anticoagulant ratio is very, very key. And when you don't have the sample enough, your anticoagulant is more, you will have effect in your sampling. All this must be trained, and then the trainers too should be able to train the people who are going to handle this sampling to be well vested. As Dr. Atinuke said, they should be able to solve certain issues that will crop up during the sampling in the community. Not everything that you have to come back for the researchers to go back to solve it. By all means, you are going to face issues, but you should be optimal, you should be clear enough of whatever you are going to do so that you will get your samples. Thank you.
All right, thank you very much. Michel?
Yeah, so outside of what the other speakers has mentioned, I think the one thing we have to highlight is the local staff capacity building, because sometimes we conduct the studies and then we bring some expertise from outside, but we don't leave something on the ground. It's very important to work on the local technician capacities so that these studies can also be a profit of the future intervention in the area, including what I mentioned in my presentation, the disease elimination. So it's very important where you implement your study, you leave some kind of expertise that can be useful for local program as well.
Thank you very much, Michel. The next question I will ask, I'll start from you, Michel. And the question is there such a thing as too much sample taking? Now, of course, research scientists like to go crazy and make sure that they have as much samples as possible to make sure that, all the offshoot questions they have, they can answer them without necessarily going back to the community. In your experience in the kind of work we do you think there's such a thing as taking too much samples, and if that has actually affected the study implementation or the biological sample process in the community?
A very good question. I think our experience is a very exciting one to ask, to respond to this question, because we had also some participants who retired their consent to the study because it was been too much skin snipped, and then they decided to leave the study. They could not give very clearly the reason, but we feel that they didn't want many samples of skin, for instance. So this is at the community level, and again, in our rural area, especially in DRC, that could be the case also in Africa and other areas.
So I'll ask the same question to Augustine. Do you think that this is the case?
My answer to this as a scientist is yes and no. The yes, because yes, we need sample. And some samples are delicate, that when you are going back, there will be issue. For instance, Anthony, if I should take your COVID sample right now, where I got to, the nasopharynx that I got to the first time, if I should repeat it, I will never get there because you will never give me the chance. So whenever I'm going in, I have to make sure that I go in, I take enough sample that I will not come back. Then it's no, because at times, we need to follow up, by all means. So my answer is yes and no. These are my reasons. Thank you.
All right, thank you. So the next question I'm going to ask Dr. Atinuke, has there been such a thing in your experience as researcher blaming? Now, you took quite an extensive samples, different samples in pregnant women. And we do understand that sometimes people may experience some symptoms, and this may be unrelated to the sample that was taken, perhaps maybe their condition and situation they find themselves in. And you can find family members blaming the research scientist for doing something to the patient. Have you in your line of work had any experience like that? And what would be your recommendation for how to handle this with the families of these patients who enroll in our studies?
Yes, thank you. Of course, there is always that possibility where people would ascribe whatever happens later to what you did. And this is particularly true in studies where we administer investigational products, for instance, like medications. So, and this is where the place of communication is so important. At the consenting, I think it's really important, first of all, as researchers, to not be in too much of a hurry to enroll people into the study. Let us take time to make sure they understand what we are trying to communicate about this study, about the product, what to expect, what not to, things like that. Because the truth is that if we get that well settled at the beginning, then this blame game is not usually as bad. You're able to come back and say, oh, remember, we mentioned this, or we said that. So they can say, oh, that's true. Oh, this is true. But if all we did was, oh, just come, we're doing this, come and join, then there's a problem. So that's where that really, I would say, is a very big thing that we need to make sure we address when enrolling people. And during the course of the study, to keep having these updates with them, getting feedback from them on their experiences so that we can clarify those that are related to our study, we should accept and let them know. Let's be upfront about it. And those that are not related, let's be clear to them as well.
Anthony, we can't hear you.
You're muted.
Our sincerest apologies. Just a quick reminder that today's recording from today's webinar will be posted on the TGHN Ghana page, and Luis has already shared the link in the chat. In addition to this, we will be asking for your feedback in a very simple online survey. Should take a couple of minutes also in the chat, and we'll appreciate if you can just use these links to access these information and help us with that. Dr. Ahiable, I would like to ask you, do you see the importance of collaboration, especially between government institution or state institution and research scientists, especially in during pandemics, to streamline biological sample processing and coordination? You did mention something in your presentation about some of the challenges that you had as a result of snags that happened between your staff and the research institute within the university in Ghana. And so how helpful can collaborations be, especially when the government decides to step in or state institutions decide to step in for biological samples?
Thank you once again, Anthony, for this wonderful question. You see, the collaboration is very key in undertaking such type of researches. In fact, there were other collaborations we did with other institutions, including the University of Ghana. We did a lot of collaboration with them. Some of them were not on sampling or biological sampling, but social one. There was another one with to determine the drug of choice we could use for the management of this COVID-19. The collaboration was good. Unfortunately, we didn't continue on because the pandemic, the numbers were now going down, so it was stopped. So I think collaboration is very, very important, because in this case that I've mentioned, the research institution at Legon, when the researchers came in first to seek consent to use our facility for research, initially there was that lackadaisical attitude from the top management. It took us a long time for us to accept them into our facility to collect data. So collaboration in this aspect is very, very important. So is that I have to come in with my background experience, work with them closely before they were able to get the access to enter into some of the facility. So collaboration is very important once again, because when we collaborate, we come out with an information or results, an outcome that will benefit the entire society. Like I said, we've done other researches, but it was not on biological sampling, and that one, it wasn't so difficult, like collecting specimen, like blood, serum, taking samples from victims, or how do I say it, participants. Now, it takes a lot of time for people to give into that. So when we start early enough from the beginning of when the proposal was written or the idea was conceived. But when we start from that time, by the time we get to the proper data collection, I think things will have streamlined. So that's what I would like to say about collaboration, which is very important, key.
Thank you very much. My last question, and we end the webinar. Michel, now, scientists do not concern themselves with logistics. Scientists do not concern themselves with customs and immigration. And when we conceive an idea, we have all these beautiful research questions, and we have these amazing follow-up time points and, you know, advanced molecular and cellular analysis that we want to do. In your presentation, you seem to have encountered a challenge that could have led to the wasting of your precious samples relating to transport and logistics. In your experience, on hindsight, do you think that it is really critical for research scientists and teams to consider the non-scientific operational components that will enable them to collect the samples, transport, and process them well?
Yes, of course. Thank you very much for this wonderful question. This was really our experience, because I have to say hello to Dr. Tony Uketi, who is attending this meeting. He was actually the principal investigator of the study, but he played more the project manager role as how to organize administrative logistic. We also set up a logistic department in the study. We had this logistic who was working with the principal investigator. Myself, I was more involved in technical field work, but the principal investigator was most also tackle the administrative and logistic tasks. So it's very important to think about it outside of the scientific questions, also to include this component of logistic, because we need really to ship, to collect, to ship, and then to store the samples in a very quality standard conditions.
Thank you very much, Michel. This was very helpful. And we'd like to end the webinar today. We'd like to thank very much our speakers, Michel, Augustine, Emmanuel, and Atinuke, for the dedication and the time they committed to supporting this and helping us to bring this webinar to you. We really do appreciate your time. We saw incredible people from all over the world joining us at this point in time to share with us in this 90 minutes of scientific content on biological sampling during pandemics in the community. And so we will be sharing the recording once again on our website, and we will reach out to you all. Thank you for your time, and we wish you the best of the day, and we will be in touch with future webinars. Okay, bye.
Bye.
Bye-bye.
Bye.